A 61-year-old man presents with severe left lower quadrant pain and fever. I am showing you an initial CT and a follow-up CT performed 2 weeks later. Describe the findings on the initial scan first.
Okay. The initial CT demonstrates focal asymmetric wall thickening and hyperenhancement involving a segment of the sigmoid colon.
And how have the findings evolved on the follow-up CT on the right?
All right. And how have the findings evolved on the follow-up CT?
Based on the combination of these two scans, what is the complete primary diagnosis?
The initial scan is diagnostic of acute uncomplicated sigmoid diverticulitis. The follow-up scan demonstrates progression to complicated diverticulitis, specifically characterized by the formation of a localized pericolonic abscess.
Why is the sigmoid colon the most frequent site for diverticulosis and subsequent diverticulitis?
Based on that, the sigmoid colon has the narrowest lumen of the entire large bowel. According to Laplace's law, this results in the highest resting and active intraluminal pressures, which forcefully drive the herniation of the mucosa.
Are these true diverticula, and anatomically, where exactly do they form along the colonic wall?
No, they are false or pseudo-diverticula because they lack a muscular layer. They preferentially form at points of relative anatomical weakness, where the vasa recta penetrate the circular muscle layer to supply the mucosa.
Beyond abscess formation, what are 3 other severe local complications of diverticulitis you must actively search for on the CT?
I must meticulously evaluate for free intraperitoneal air, indicating a frank bowel perforation, the presence of fistulous tracts to the urinary bladder or adjacent bowel loops, and large bowel obstruction secondary to chronic stricturing.
What rare but potentially fatal vascular and hepatic complications can arise from severe diverticulitis?
Severe inflammation can lead to septic thrombophlebitis of the inferior mesenteric vein. This can propagate into the portal vein, a condition known as pylophlebitis, which can then rapidly seed the liver with hematogenous bacterial abscesses.
If a patient presented with similar left lower quadrant pain, but the CT showed only a small, fat attenuation mass with a hyperattenuating rim and a central dot with a completely normal colon, what is the diagnosis?
If we look closely, that specific appearance is pathognomonic for acute epiploic appendagitis. It is a benign, self-limiting torsion or thrombosis of an epiploic appendage that clinically mimics diverticulitis but requires no surgical intervention.
How would you manage this patient as a radiologist, specifically addressing the new pericolonic abscess?
Well, given the large size of the new abscess, I would urgently consult interventional radiology. I would recommend performing a CT-guided percutaneous catheter drainage to achieve definitive source control.
Once the acute infection and the abscess have completely resolved, what final management recommendation is mandatory for this patient?
Okay, I would strongly emphasize the need for a follow-up optical colonoscopy in approximately 6 to 8 weeks. It is radiologically difficult to definitively exclude an underlying perforated colonic adenocarcinoma masquerading as severe diverticulitis.